Here we will kind of slowly get rolling with our next presentation. A special invitation to Colonel Mustard, and it's great to have you. Thanks so much for being here.
Thanks for having me. Is this
Yeah.
button's on? There you go. Thank you for having me. Happy to be here again.
Yeah. Were you paying attention during the mic teaching?
I was.
Yeah, there it is.
Closer. Yes, I am now ready.
Can you tell me about your props that you brought on stage today?
Left the comb in my pocket on the way from the hotel, so I just decided to throw that in there. And then I got a magnifying glass.
Nice, I love it. We are going to be jumping in. So our next section is going to be the case of the cloudy lens. And if we can click on that, so I'll be able to advance forward, that would be super awesome. Beautiful. So we're going to jump into this. Our victim in this episode is the cloudy lens. So, a quick background, when we're going to be talking a lot about cataract surgery, refractive cataract surgery, advanced cataract surgery. But a reminder, I love that sneeze, and bless you. No, you're good. Don't even worry about it. No apology needed, but bless you. When we're talking about the lens, we're really seeing patients with cataracts that typically have had two things affect their lens. In their 40s, they've lost the natural flexibility or accommodation of their lens, and so they've started to feel the effects of presbyopia. And then again, the majority of patients who are, past the presbyopic stage and that we're seeing in cataracts now have a cloudy lens. So they have a cloudy lens that's also lost flexibility. And so we're talking to them about, hey, what can we do to remove that lens? What options do they have when it comes to surgery? So Sierra, I'm going to throw this one to you. I'm curious, when you're seeing cataract patients, what background information are you most interested in? When you're looking at referral notes, what's kind of most valuable to you prior to going in to see a patient? What are the things that you're kind of wondering about? And then what are you asking the patient about to help inform that decision?
You have all the answers up there already, so.
Well, you can have other answers if you want.
Yeah, mostly I would say it's helpful when you guys have kind of had the conversation with the patient ahead of time, put that in the note. So what their end goal is after surgery. Do they want to be out of glasses for everything? Do they want to stay nearsighted? Prism in glasses is helpful to know. I would say mostly what their goals are. If they've had any previous strabismus surgery, if they're amblyopic, all of that stuff is really helpful and not something that we always know unless it's been put in the chart or the patient has a good recollection. Help me out here. Recollection of all of it.
Perfect, Miss Scarlett. That was excellent. And then I think the other one that's also really nice is, again, if a patient's been in monovision, it is incredibly helpful to know, or if they've tried monovision and it didn't work, just for us to know that and be aware of that. Because a lot of patients will ask about monovision during a cataract eval, whether they've already had it or they just know a friend who had it. It's really helpful to know if they've trialed it, because in general, we will not trial monovision with cataract surgery, meaning we're not going to use that as the opportunity for them to try it, because there's a 20 to 25% chance they will dislike it, and then they would need an IOL exchange, which wouldn't be super great. So as you're thinking about looking at a patient and the clinical exams that we're doing, Travis, so I put up a bunch of stuff that we do: higher order aberrations, topographies, OCTs, optical biometry. What are you looking at with those tests, and how do they kind of help inform your decision making for a patient?
I think this is part of the conversation I have with the patient. Once I sit down, they don't always make this, but there's typically a comment of that was a lot of tests. And I tell them, you're here for blurry vision. Something's changed in your vision. Your doctor sent you here. They've talked to you most likely about this. And we want to verify that your reduced vision is caused. Is it only by the cataract? Is there a corneal issue? Are there retinal issues? Is there a macular component? And really to properly set expectations. For patients that say, well, my friend had cataract surgery and it didn't work, I'm kind of well, it worked, your cataract's gone, you just might need glasses still. Or you had macular degeneration, or you had, keratoconus or corneal scarring, or whatever it may be. So I basically skimmed through what our testing shows with an intention to look for anything else that could be contributing to their reduced vision. And then that kind of helps guide me through my conversation when we get to the conversation around what are their desires for their vision after surgery, with or without glasses, limiting glasses, to help that kind of guide the conversation.
Perfect. And I think, Ms. Scarlett, did you have something you wanted to add?
I was just going to add the history piece and the complaint or the visual symptom piece is really important to listen carefully to what the patient is saying because, as Travis mentioned, a lot of times they have a cataract, but they're dry or they have macula stuff going on, and patients still seem to think, even though you guys have all had the conversation with them, that cataract surgery is going to be the cure-all. And so listening to those symptoms, making sure the patient understands what symptoms are cataract related and what symptoms might not be cataract related is a big part of the talk we have with patients, just to kind of reiterate what you've already told them.
Yeah. And I think, if you look at all the suspects up here, Miss Scarlett loves her topographies. The topography, this is a great example of where topography is really valuable. You have one topography showing beautiful with the rule astigmatism. That would be a great patient that could have a nice monofocal toric lens or would have low higher order aberrations and can do an EDOF lens or a diffractive trifocal lens. Or you have a patient with maybe similar amounts of astigmatism, but it's an irregular pattern, post-RK or a decentered historical myopic ablation or whatever it might be, where again, our options for patients and what lenses we might consider are going to be dramatically different. So, Colonel Mustard, patients, on average, cataract surgery in the US, if we look at all the data, on average patients are 65. Again, there's a wide range.
73, actually.
No.
Yes, American average for cataract surgery.
Just 73. In North Dakota.
I would say our age is 65 though, but you're wrong at 73.
So patients who are making a big decision in their life, where they might be making a 10, 15, 20-year decision of how they want to use their eyes, or maybe it's a myopic patient, highly myopic patient who's in their 50s. How are you talking to them about the decision that they have when it comes to cataract surgery and what lenses they might choose and what options they might have?
Ultimately, I want to know their goal, and everybody, maybe loves the idea of getting out of glasses, and sometimes we can and sometimes we can't. Sometimes patients are a good candidate for all the choices, sometimes it's only one or two. So I kind of break it down into, here's what I like for you, here's what I'm okay with. But ultimately needing to know the ultimate visual potential, just because you don't want any surprises after surgery. It is a lifelong decision. And it surprises me how many patients don't realize that with cataract surgery, we're not cleaning the cataract, we're removing the cataract and putting in a new lens. And if we don't, you're gonna wear glasses that thick. And so a lot of patients actually don't know that with cataract surgery, you are putting a new lens in the eye. And then when it comes to decisions and options, they get overwhelmed. So once they know that we're gonna be putting in a lens regardless, and here's a couple choices, which one sounds the best. But patients can get overwhelmed in the exam room, so oftentimes I'll say, take a week to think about it, I'm gonna call you in a week, we can revisit this conversation. Sometimes the spouse is not in the room, so we're having the conversation again on the phone a week later, but all of our patients don't leave with a decision, and that's okay.
Yep. And when I think about that, patients, they have cataract, and maybe that's new news, or they've known it for a while. They have astigmatism, but maybe they never quite understood that. You're talking to them about lenses that can give them back some of their reading range. I do think it is a lot of information for a patient to come through. And, our goal is to try to make that clear as possible, but also, as you said, be able to repeat it and be okay with that. Because I think that's an important thing. It is a big decision, and sometimes a decision they may not be ready to make while sitting in front of you. So
correct.
So one of the things, I'll be quiet and we'll listen to this one, and we'll talk about it for a second.
Available for them. You can see here, the patient will be in a room or an apartment. We can also put them in a car.
I'm actually going to go back first before this video plays. So just to give an introduction to this video. So this is actually a new technology that we've started using for all of our patients. Because one of the big things is, when we via words describe, hey, what does it mean if we do or don't correct your astigmatism? What does it mean that you're going to be, go from -2 to plano and lose your near vision? Or what does it mean to have an extended depth of focus or multifocal lens that pulls in? Our kind of word descriptions of that, and then a diagram picture, was sometimes hard to demonstrate to patients what they would actually experience. So the video is going to show a new technology that we're using, a virtual reality technology called Green Man that actually a couple of my partners helped create, that basically simulates for patients. We can take their actual optical biometry information, we can take their amount of astigmatism, low, moderate, high, plug it in. So if they have 1.7 diopters of astigmatism, we can put that in. And then we'll be able to demonstrate to them in a home environment, in a driving environment, hey, what would it look like if we corrected your astigmatism? What would it look like to have a multifocal or not have a multifocal? What does glare and halos look like when you're driving at night? So I'm gonna roll the video so you can kind of see, but it's been a really nice experiential education for our patients to be able to try to understand even a little bit clearer as they're going into making that decision, what options
The patient will wear a virtual reality headset and someone will control the different options that are available for them. You can see here, the patient will be in a room or an apartment. We can also put them in a car and they can see what that environment would be like. Two very common things for people that are living life and about to undergo cataract surgery. We use their own eye measurements to estimate what their postoperative outcomes would be like. Here you can see what it'd be like with a standard monofocal IOL before they get their glasses. This would be a monofocal toric IOL, meaning they can see well in the distance, but they're not going to have super crisp vision up close. They can interact with the environment and get a sense of what it'd be like to read a book or look at the distance, and they can see and feel what it would be like if they chose this lens option. This is a multifocal IOL, meaning they can see good in the distance and good up close. Again, they can interact with things and get a feel of what life would be like if they chose this IOL option for their cataract surgery. We can do a lot of things with this environment. We can dim the lights, we can move them around. Again, they get a sense of what it's going to be like after they have cataract surgery, but before they have to do anything.
So Alicia, super curious for you, just your perspective on patients' experience with this and how you feel like it helps them maybe understand the choices that they have a little bit better.
Ooh, there we go. I've really liked it with my patients. I have found that patients appreciate, it's more the near, I would say, those individuals that weren't necessarily thinking that they wanted to even consider doing an advanced implant or our trifocal option, and they see, oh, this is what my vision could look like with a standard versus a toric. I actually have a fair amount of patients that do like the options between a standard and a toric and actually correcting that astigmatism, and then they're okay with the idea of just wearing readers all the time for up close. But I think it gives them a really nice, good, like, real life, as much as their cataracts can allow them. Another thing that I love with Green Man is it's going to show some halo effect with our trifocal implant. And a fair amount of patients will tell me, I was expecting, way worse. So I have found some patients that have found like, oh, that's not too bad. And then they come back for their post-ops and they have reported to me that it was quite similar. So it's been a nice simulation.
Did you have other thoughts on that, Colonel Mustard?
We use it a ton in Fargo. It's been really helpful. And where I love it is what every patient, wants to ask but doesn't know how to ask it is, so how good will my vision be with like a standard monofocal? And so we look, and if, most Americans actually have less than a diopter of corneal astigmatism. So if that's the case, likely very well. I say we got two scenarios. You'll either wear a thin pair of glasses or you might find you can get by with reading glasses. But for our patients with like $1.50 too, how blurry is it going to be? 20/70 probably. How blurry is that? So you can dial in the 2 diopters of uncorrected astigmatism in the VR and they can see that. How bad are the ring and halos? What does it look like? Honestly, previously I would have, my mother-in-law has a diffractive trifocal and I would have patients call her and talk to her because I can't tell you what it looks like. So I would.
Your mother-in-law must really love you.
I know. She should probably receive a commission. She doesn't. But this has led to less patients calling my mother-in-law.
It's a big win. Big win for you.
They got to talk to somebody with the technology in their eye. I can only tell you what people tell me.
Yeah.
And this is a try it before you buy it. It's super educational, shortens the conversation and my time in the room.
Yeah. And one of the things, and I think this goes to the point, we have all these different advanced lens options, and we're going to walk through some and then go through some cases. If we were talking to patients about 6 or 7 or 8 different lens choices, it can be really overwhelming. And so again, part of our job as we're looking at their evaluation, part of our job as we're looking at their desires of what they want. Part of our job as we're reviewing your guys' referral notes is to kind of say, help guide that and kind of say, okay, here's the 2 or 3 options that you would have that would make the most sense depending on what visual goals you have, and drive that. And I think one of the things I also like to remind people, and this goes into the part about presbyopia, sometimes we're doing cataract surgery on a patient who's 45 or 50 or 55, and even though they're presbyopic, they still have some accommodative amplitude left in their lens. They also have a lens changes that's creating a little bit of extended depth of focus just from the spherical aberration that the early cataract changes are happening. So if you add spherical aberration from an early lens change and cataract change, plus a little bit of accommodation in a 55-year-old who's like, well, yeah, I don't have a lot of range of vision, I'm still throwing on reading glasses, but they actually might still have some degree of range. And we put a basic monofocal implant that takes them to absolute presbyopia with a lens that does not have induced spherical aberration to give them additional range of vision. That's a pretty big wake-up call for some patients where they're like, oh, that was a change. Like I used to felt like I had a little wiggle room even with my reading glasses. And so again, just important for patients to kind of understand that aspect of it.
Quick question from the audience was a question around, have we used Green Man to simulate monovision for patients that have done that? Nick, you want to speak a little bit to that?
Honestly, I don't know if we have in Fargo. I mean, we can. I don't talk about monovision much at all unless someone's done it previously with contacts. Because if you haven't done it previously with contacts, you're going to hate it. Either love it or you hate it. Most patients don't like it if they haven't trialed it. So we could emulate that with Green Man. But for somebody who hasn't tried it, putting them through like a month-long contact lens trial, I haven't done that, and
I don't think it would take the place of a contact lens trial. Yeah. Like the simulation isn't going to be enough real world experience, in my opinion, to feel comfortable doing monovision on a patient that's never done it. But you could show them different lens options in monovision if they've done monovision. So here's what monovision would look like with a monofocal lens, or with a EDOF lens, or with a toric lens.
Yep. Yeah, so the answer is you can demonstrate monovision. It's actually designed that you can demonstrate it, but to the point, it's for someone who's never done it, a 3-minute demonstration in a VR setting is not sufficient to know how they're going to neuroadapt to it. I maybe just turned 40 this year, and I did try the monovision setting. It was kind of interesting. My brain wasn't super happy with it. But when we think about advanced lens options, just so you guys know, because sometimes you might see all these different lenses coming back, and I think it's kind of helpful. There's kind of what I'll call a newer class of lenses that honestly is pretty rarely used that are termed monofocal plus lenses. The idea is that maybe they do have a little bit of extra induced aberration profile. Just to be quite frank, most times we're doing a regular monofocal as opposed to an enhanced monofocal lens implant for patients, because for most of those patients, they're going to be just as happy in a basic monofocal. These ones cost a little bit extra to the system, and they don't really get, in my opinion, a great additional benefit. That being said, the light adjustable lens or the light adjustable lens plus or LAL plus lens, you can induce a little extra induction. We'll talk about that with some of our cases. So there are some applications where it can be helpful, but for the non-adjustable monofocal plus lenses, it's not a lens that we classically use a lot of. The extended depth of focus lenses, we'll talk about those. There's kind of 3 classes of those. There's the pinhole aphthera lens. There's what we call wavefront modifying lens. The one on the market right now is Vivity. And then there's a diffractive extended depth of focus lens, Symphony. And then we have refractive bifocal lenses, which are kind of newer to the market. We actually have not implanted any in Montana yet, but we'll talk about them. And then diffractive trifocal implants. And again, you can kind of see, you go from less range at the top with maybe a higher degree of contrast because you're not splitting light, to more range of vision, but a little loss in contrast sensitivity, which is why, again, we want to make sure these patients don't have higher order aberrations, that they don't have retinal pathology or optic nerve pathology that would interrupt with that as well. So, I'll take toric IOLs first. Again, toric IOLs, as Alicia mentioned, are just like, they're a beautiful slam dunk for patients who have had astigmatism all their life, has been corrected in contact lenses or glasses, and can be a really beautiful option for those patients who are, okay with still needing some reading glasses for up close, but like the idea of great distance corrected vision. And also, to the point that Sierra made, sometimes we have a monovision patient who has a high degree of astigmatism. And so we may do monofocal toric lenses in both eyes, one for distance, one for up close, if they've historically been in a soft toric contact lens for their monovision. So a really nice option. Does, again, create absolute presbyopia. There's no range of vision with a basic toric IOL. So they are still going to need that, and we can do a LASIK or PRK fine-tune afterwards should we need it.
New in 2025, I believe. Envy is new in 2025. And so we've got these powers that can correct a ton of astigmatism, and now we actually have lower toric IOL powers, which is super awesome.
Yep.
Because previously I think we had like a 1.5 in the eye, which is a little more than 1 at the spectacle plane, and now we've got a 1.25 for like a 0.9 at the spectacle plane. So it's nice. It's led to like less laser fine tunes and more options to nail the astigmatism now with these lower toric IOL powers.
Yeah, that's a great point. The light adjustable lens, I'll throw this one to you, Alicia. Can you talk a little bit about the lens and kind of the process for a patient who's maybe undergoing a light adjustable lens?
Yeah, so I really enjoy working with a light adjustable lens. When I'm thinking of who might be a nice candidate for a light adjustable lens, patients that have had prior refractive surgeries, LASIK, PRK, I think they do a really nice job because those corneas are just a little bit more irregular. They can have a little bit higher order aberrations, and I think this lens does a nice job not emphasizing that. And as well as patients that have done previous mono that have, again, a little bit of irregularity to their corneas, I think this is a great lens that I reach for with monovision. With this lens, I kind of set the expectation that we're going to get to work together a little bit more. The lens goes in as the typical cataract surgery would, and then after, it depends if they've had previous refractive surgery, then I wait for 6 weeks post-op to start something called light treatments with the light delivery device. If they haven't had prior refractive surgery, then we can start at a month. And if they've had something like RK, I'm waiting for about 2 months. So it kind of depends on if they've had prior surgery and when we'd start these treatments. But what these treatments really entail is it gives us the customizing ability to really fine tune and get this prescription right where we want. So it kind of gives us a way to test drive, so to speak, with different types of vision. Sometimes I have patients, my common one is actually hunters in Montana. They want their best distance vision, but then I'll put both eyes for distance with their treatment. And then they're like, oh, I want a little bit more for my bow sight or my gun scope, something like that. So then I'll commonly give them a little bit of a monovision split then, and it's not your traditional monovision where you're one eye, plano, one eye -2 to 250. It's much smaller than that. It's actually like a plano and like a 75. The process is I check their prescription, they would be dilated, and then a little lens is placed against their eye, and a UV kind of light beam goes in and can change the shape of the lens. We have to do 1 treatment. We can do up to 3, so it really gives us time to kind of customize right where the patient would like their prescription and their vision. And we do those a week apart, at least. So it gives them a really nice kind of real-life experience with them. And then we do 2 lock-in procedures, and that's just a different beam, a little bit longer, and it solidifies those polymers in place, so then the lens shouldn't be changing over time.
Perfect.
That would be the one lens where I would consider a monovision conversation with a patient who's never done it in contacts before, because you can adjust them in or out of it if you need to, with contact lens trials in between.
We do a ton of it. I don't even like calling it monovision. I just call it blended. Like the patient I locked in last week, the reading eye, J2 20/30 in the distance. And the way we can get away with that is, when you're picking an IOL power, sometimes it's first minus, second minus. Myopic blur is a lot more tolerable than hyperopic blur. So with all cataract surgeries, surgeons are usually picking first or second minus. I tell our surgeon, Dr. Greenwood, I need you to miss hyperopic. And we do miss hyperopic with this lens because when the first light adjustment is a hyperopic treatment, just like a hyperopic pair of glasses, you are fattening the center of that lens. With the treatment, you are changing the shape, fattening the center of that lens with that hyperopic light treatment, and you are building in some added extended depth of focus to it. So I don't like using the word monovision because it's not full monovision, it's blended, and a lot of times the patient's reading eye is 20/25, 20/30. The results are awesome. It's the process that they have to be committed because they're coming back again. and again. And they can try something, and you can change it. And I'll never forget the gal I had last year. She said, I play golf, give me distance. All I want is distance. After the first light treatment, she was 2015. I'm thinking locking this in. I walk in, she is so mad at me. And I was like, you see better than I do. What's going on? She's like, how did you expect me to put my makeup on? And I was like, I know I didn't consider that, sorry. And so we, because she can't put makeup on with reading glasses, so we did, give her a little bit of near. She wanted a little bit more. And once again, the reading eye was 20/30. Pretty awesome. So it's a blended, modified mini monovision.
I mean, I would think with how you manage your mustache and your awesome hair that you would have had some consideration of the makeup situation, but no, nothing?
She's very happy now.
I love it. So I was going to hit just on a couple of our extended depth of focus lenses. So the first one I was going to just hit on, and then we'll run into some cases, is what we call a Vivity lens. It's a wavefront modifying lens. And what's nice about this lens, again, it does not give the patient the range of a diffractive trifocal. We kind of say distance to arm's length. But when you look at, and we'll have a couple slides that show this, what we call degree of bother. There's standard vision questionnaires that now are part of every FDA IOL study that's done that ask patients in a very systematic way about the amount of glare they experience, the amount of halo, and the amount of starburst. And when you look at that, again, blue one is the Vivity lens, gray bar is a standard or basic monofocal lens. It actually performs very similar to a basic monofocal lens in terms of degree of bother from glare or halo or starbursting. And actually, the high degree of bother, meaning bothered somewhat or quite a bit, is actually higher in a basic monofocal implant than the extended depth of focus lens in the study data. So again, it is important to, one of the things you'll see when you look at these charts for this and a diffractive trifocal is, again, patients with a basic monofocal lens can still have glare and halo and starbursting effect. And so it's not that a basic IOL doesn't eliminate that risk. It is the lowest risk along with this EDOF option. The other extended depth of focus lens that we'll sometimes use and we'll see a case of later is an Apthera lens. So this is a pinhole lens. It was actually brought to market for the non-dominant eye for presbyopic correction and a degree of kind of blended monovision. However, primarily in its use clinically, it's actually primarily used for highly irregular corneas. So post-RK, post-PK, patients with very, very irregular corneas with a high degree of aberration will be using this pinhole effect. Just like we see patients' vision improve when we do a pinhole in the clinic, the size of the pinhole and the fact that it's closer to the nodal point, again, still allows them to have very good vision, although they will often notice some nighttime dimming. And YAGs on these are really tricky for what it's worth. We'll talk about that in the laser section. Rotational asymmetric bifocal lens. So this is a newer lens that's now out on the market. This seems a little bit unusual. Nick, have you guys implanted a few of these in Fargo?
We have not in Fargo yet.
So a couple of our sites have been part of the trial for this lens. But this is effectively a lined bifocal lens that's placed in the eye. And so part of the light that's coming in gets focused at distance and part of it gets focused at up close. It's currently not available in an astigmatic or toric correcting option. But for patients who are maybe interested in an increased range of vision, particularly getting into near range, more than an extended depth of focus, but are very concerned about the haloing profile, they can get this. They sometimes still will get sort of a different light phenomenon from where that segment hits. So it's not that they eliminate photopsias or dysphotopsias afterwards, but it does have a different profile, not the classic kind of haloing that we would see. And then the last one is a diffractive trifocal. And again, this is kind of our, what I would say, go-to lens for patients with a beautiful normal eye that are most interested in the greatest range of vision. Again, when you look at the defocus curves on this, which are fun, but I tell patients, our goal is 90-95% of life they can do without a pair of glasses and still low light reading, dim light reading, or extended, fine print reading, they still might need a pair of reading glasses. But the vast majority of things, cell phone, tablet, computer, speedometer, being at a store, hopefully would feel comfortable in their vision with this lens. Again, diffractive trifocals, it is important, and we emphasize and tell every patient, you will experience nighttime haloing particularly at night. That tends to lessen over time as they go through the neuroadaptation, but they have to plan on that being a part of their life. And again, that's where Green Man's really helpful to simulate that. And we can actually modulate the amount of glare profile on that. So it kind of has like a low haloing profile and a high profile. So our technicians can actually modulate that and show them, hey, this is kind of like what, if you were to experience this a lot, what they could experience. And again, important that they know that, important if they were really, really bothered by it and didn't neuroadapt, we theoretically could exchange it. It's just really unusual that we have to do that. So we're gonna jump into cases. Mr. Blue-Green, you get this one first. This is a hyperopic lover of LASIK. So a 68-year-old man, decreased vision. He had his refractive history had hyperopic LASIK in 2010 for both eyes, monovision, right eye distance, left eye near, and then had a lift flap laser and a repeat laser 1 year later. This is the patient's uncorrected distance visual acuity, came in 20/60, 20/25, has some hyperopic astigmatism, bats down, does refract still to about 20/25. History of tamsulosin use with kind of borderline to poor dilation. What I mean by that is kind of around the 6 millimeter zone, and motivated for some degree of spectacle freedom if able to. So these are our choices. This one is, hopefully our polls are gonna be interactive and live now, so you can see if you can pull up on your phone to be able to vote on this. And while we're voting, Travis, I'll let you take a swing at this. We have a monofocal IOL, a toric IOL, light adjustable lens, extended depth of focus, or multifocal for this previous hyperopic LASIK with a history of monovision.
So he did dilate poorly, or are we just assuming?
Yeah, correct. Did not dilate past 6.5 millimeters.
Okay.
Yeah, I would say that's one of the key components, obviously, with the previous LASIK. Patient desires to be limited use for glasses. I think, normally I think the LAL, the light adjustable lens, has a potential option here, but with poor dilation, it limits our ability to use the light delivery device to polymerize the lens and change the power of the lens. Given that, his topography looked fairly normal, but hyperopic LASIK is always a little bit of a wild card. So I'd either, how much astigmatism did we have? Corneal still?
It was like about refractive was like 0.75, and topography was like 1 and 1.25.
I'd probably talk to him about, potential just toric IOLs targeted for distance. You'll wear reading glasses.
But he wants a little extra freedom in vision.
He does. An EDOF lens, this Vivity lens, option 4, has the potential to give him that. And depending on what he wants from a near vision standpoint, I tell these patients, EDOF does not eliminate reading glasses. You will still need reading glasses. It gives you good kind of distance to dashboard vision. And so if you're out and about without your glasses, you can typically kind of hold things out and see it well here, but really try to educate those patients. Like, your normal reading range is not clear. You'll need cheaters for that. And so that's where there's potential of a little bit of a staggered kind of mini monovision option too.
So your final choice is?
I'd probably go EDOF.
Okay. I like multifocal.
You like a multifocal with that topography in the left eye?
I mean, so we ran like a wavefront. We ran the HOAs are fine.
The HOAs in the left eye are elevated.
Higher aberrations, normal. That's what it says. So
that was for the right eye. That was for the right eye.
If that's the case,
Don't say that, but that was normal for the right eye.
So they're high in the left eye.
Yeah, sorry. But you could still do it.
How high?
0.8.
I mean, do you think the chances of needing a laser fine tune are equal EDOF versus multifocal?
I think they're lower in an
With an
EDOF,
EDOF?
personally.
Then maybe I take back my vote, but the aberrations said they were normal, so.
That's fair. If they were normal, it actually is a great point. You theoretically could still do a diffractive trifocal lens. This patient, we did do an extended depth of focus toric implant. Patient's doing well. Again, goal of independence, but knowing that they were still going to need reading glasses. And as was mentioned, a poor candidate for an LAL just because of their dilation. So this patient is a cone, 68-year-old man, decreased vision OU. Sarah, I'm going to throw this one your way. Long-standing stable keratoconus, has known about it for 30 plus years, has not been progressing, unsuccessful with scleral lenses, visual acuity 20/70, 20/80, 8 diopters of manifest refraction, but only gets like a line better improvement, 2+ nuclear sclerotic changes, irregular cornea with thinning. You can see the topographies there. That went really fun. Wow. Somebody jumped ahead for us. Let's go back this way. Okay. Topographies show 5 diopters of astigmatism. How are your hyperopic eyes handling this today? Not good. Oh, man. Nick has a magnifying glass if you need it over there. Okay, so this patient, the cone with glasses, what options are you giving him? And you can give him more than one option here of a monofocal, a toric, a light adjustable lens, EDOF, or a multifocal.
Did you say he had 8 diopters of astigmatism?
Refractive astigmatism.
Do you guys look at refractive astigmatism? Because I don't.
I pay a little bit of attention to it, but I mostly care about their topographic astigmatism.
Mm-hmm. And 6 on the...
5 on the topographies.
I would probably lean toward a monofocal. You could potentially do a light adjustable lens and just let him know we can maybe knock back some of the astigmatism, but it's not going to correct all of it. I think it would depend a little bit on his motivation level and did he dilate?
He is a classic hunter in Montana, and he's motivated to see a little clearer at distance, if it's possible.
Yeah, if he had
and he doesn't tolerate scleral lenses, and he's got a lot of astigmatism. Doesn't love his 8 diopters of astigmatic correction in his glasses, but
you just want to point
still
to
like
the
a
lens
basic?
You want me to choose?
No, I'm just wondering.
If he had the right personality, I would consider a light adjustable lens with a lot of education that the goal would be to reduce the amount of astigmatism and reduce the prescription in the glasses, but that it is not going to get him out of them.
What about just a regular toric?
Does he dilate?
He does.
Yeah, maybe. I mean, yeah, sure. If you wanted to.
I don't mind.
I don't mind a toric. He's not super skewed. He's not super skewed, so yeah, potentially a toric as well.
How much corneal astigmatism? Is it 5?
5+ diopters.
And what's the pachymetry? He looks pretty thin on that right eye.
He's pretty thin, so he's sub 400 in the right and 420 in the
Correct swell in glasses?
Correct's not great
good.
right now, 20/60, 20/70 in glasses.
You're not going to get him there with a monofocal toric. It rotates a little bit. I mean, rotational stability on these things is awesome, but you're not going to get him there. I think with the light adjustable lens, you can go 4 diopters in either direction. I think you'll probably get him closer. If this guy's a hunter and wants the best vision possible, he needs to retry a scleral contact lens.
He does. His daughter actually works in an optometry office, and he's tried many times at her request and has failed.
Right.
Okay, so this patient, actually when this patient had surgery, for what it's worth, you'll see later on, this was pre-light adjustable lens being available. So this was 6 years ago that this conversation had. So I put a toric lens in this patient and came back. We watched him at 3 months. He's, a mixed astigmatic. We shot for a spherical equivalent target. He's 20/50, 20/60, but actually refracts a lot better. Doesn't have cataracts. Surprisingly refracts. I didn't think he would refract this well. But now 2 diopters of astigmatism. A stable cornea for the past 30 years. Okay, Alicia, are you telling him he gets to get new glasses? Are you telling me he should retry a scleral lens, that he's fine to have a PRK fine-tune, he's fine to have a LASIK fine-tune?
Oh, my gut tells me scleral lens, but apparently he won't do them, right?
Well, he still doesn't want to do a scleral lens. And also doing a scleral lens in somebody that has a T9, 4.5 diopter, you'd have to do a bitoric, so a little harder fit. But his prescription with a pair of glasses gets him to 20/20. So what?
I'm gonna let her off the hook here because I have a comment for this. I remember seeing this patient in the clinic and literally scratching my head at what happened here because it was before my time, and I just continued to look at it and was like, why? But it turned out really, really well, and it just didn't make sense. Normally I'd look at this and I'd say, well, you tell them this is as good as we can do. You correct the 20/20, here's your new glasses. Potentially look at soft torics now.
Yep.
You may not need a scleral lens. You may do well in a soft toric at that point. You've reduced the astigmatism. He corrects better in glasses, so he should do well in a soft toric. But I believe he had PRK.
He did have PRK. I really tried to convince him to be in glasses. But I also told him we could consider PRK. So we actually did, again, he had been stable for a very, very long time. His treatment was, a spherical equivalent neutral treatment, so essentially not taking away a lot of tissue. We did a PRK treatment. He's now without correction 2025, and I told him he gets a serial topography pentacam with us to continue to check and watch and see how he does. But again, 6 years later, doing super well. And for a guy who's, Mr. Independent, living in the mountains, not wanting to come to town for anything, he is wildly ecstatic and super awesome. And to the point, again, in today's day and age, like a light adjustable lens would be a great option for him. Can't quite kick as much as a traditional monofocal toric, but just to highlight a potential option.
Do you remember if you did a topo-guided treatment? Or
No, this was not a topo-guided treatment. Okay. He had a very regular pattern, and we talked about he had a little bit of mild skew, but we felt comfortable it was still right on axis with the uncorrected astigmatism that he had. And so we just did a wavefront optimized treatment. Great question. Okay, case of the carved up cornea. Who should we pick on for this one? Nick, I'll let you get this one. Okay, this patient, we'll go back here. 60-year-old SAS post RK in the 90s. He's 20/60 in the right, 20/40 in the left. You can see the manifest refraction, which you don't care about, but +4, -2, +3, -1. 16 cut RK in the right eye, 8 cut RK in the left eye, 2+ nuclear sclerotic changes. And here's his two clinical topographies. Macula looks beautiful in both eyes. More irregular corneal shape in the right eye than the left eye. And the question for you that you get to take with this one is, what would you do for this patient? Monofocal IOL, toric IOL, light adjustable lens, pinhole optic, or extended depth of focus? And I'll go back to our
Nick,
topographies.
I have a couple questions. What?
Before you answer, would you clarify the why behind you don't care about refractive astigmatism versus corneal astigmatism?
Yeah, refractive astigmatism plays no role in a calculation or, a lens pick for cataract surgery. Which sometimes I'll get, we get referrals and it's discussed options. Low refractive SIL, recommend monofocal. And, there's two places you can have astigmatism on the eye, cornea and the lens. And there's lenticular SIL, and lenticular SIL can add to corneal SIL, or lenticular SIL can negate corneal SIL. And so we care about how much corneal astigmatism is present because that's all that matters when we're putting a lens in the eye. I've had patients with 2 diopters of refractive SIL, and it's spitting out, low SIL with the monofocal post-refractive, and I've got low refractive SIL that are predicted to have 2 diopters of refractive SIL with the monofocal. So refractive SIL can clue you in, but it doesn't tell you what you need to know, whether the patient requires a toric.
Yeah, and it's the hardest one of those is a patient who has never had astigmatism correction.
Correct.
And their glasses or contacts. They have lenticular SIL that's minimizing their diopter and a half of corneal SIL, and we're talking to them, hey, if we do a basic monofocal lens, we're removing your lenticular astigmatism. If you don't correct your astigmatism, you're going to take a step back in uncorrected distance visual acuity.
Correct.
They have to realize that.
Yeah, it's a hard
okay.
conversation. How much corneal SIL on this patient?
This patient, if I remember correctly, had about 2.5 diopters of irregular SIL in the right.
Okay.
So the manifest was that. It was 2.5 and 1. But the topography on the right had about 8 diopters of lateral asymmetry and superior inferior asymmetry in the 3 to 6 millimeter zone. And in the left, I believe, was like 2 diopters of irregular difference. So like if we were to zoom into the numbers, and I apologize, but I think it's like 33 to like 42 is the range of difference within the 6 millimeter zone. So it has quite a bit of central irregularity,
Okay.
Even though he doesn't manifest it. And the left was less, like 2 to 3.
And the go back one more slide, please. The
Yeah.
visual acuity was there. That's best corrected
Yeah, best corrected was 20/60, 20/40.
with the 2NS. I would do a Apthera in the right eye, and I would do a light adjustable lens in the left eye. That's what I would do.
Okay, so the second question was, which eye were you going to do first? We did do an Apthera in the right eye, as you had suggested, the very irregular cornea. And this patient came in day 1 and was so ecstatic. They're 20, 30. They've had a high degree of irregular corneal astigmatism for a long time. They have a well-centered Apthera, and they say, hey, we told them, hey, we usually don't do these a day apart, even though all of our other cataract surgery is done a day apart. We usually wait a week or a couple weeks to just see how you're doing. And he's like, no, but I want the left eye done today. And we said, no, you have to come back come back in a week. He comes back a week later, still seeing great, was like, oh, I see what you meant when you talked about my right eye might seem a little dim at night. We just talking about waking up at night and trying to walk to the bathroom, or otherwise noticing the dimming, because even though his pupil's dilating, the optic pinhole is not dilating, and so he's not getting as much light into that right eye. And so he elected to then not move forward with an Apthera in the second eye. This would have been a great case where we actually could have done light adjustable lens. He chose to do a basic monofocal lens in that eye because, again, his historical refractive astigmatism wasn't manifesting as much, and he ended up doing really well. So he had a basic monofocal lens in the left eye, 20/20 at distance, again, 20/60 at near, not as much near, more near in the uncorrected Apthera eye. And again, even with the Apthera, one of the interesting things, it neutralizes the effect of the astigmatism, but actually if you go to measure for their glasses, oftentimes they'll still manifest their astigmatism through that because they'll still like the image quality from correcting it. So again, he ended up not choosing to get a pair of glasses for his correction, but glasses would have still made it even more clear for him should have he chosen to do that.
And the FDA label on that Apthera is to have in one eye. Not that you couldn't put it in, have you put it in both eyes?
I have done it on one patient, yes.
Okay.
Yeah, you typically, the concern is that it causes too much nighttime dimming, so it's more commonly we're putting it in the more irregular eye on the other side. Okay, this is, I'm gonna run through this one really quick. This is another hyperopic LASIK patient. We have all these patients that we did not do hyperopic LASIK, but, so this is patient 67, history of refractive, history of hyperopic LASIK, +3, +4, also had a lift flap laser. Again, not uncommon to see with high hyperopic LASIK treatments that they will have some regression. And this patient, again, 20/30, BATS to 20/70, 20/80, they dilated very nicely, motivated for spectacle freedom, as many of our post-LASIK patients are. You can see the kind of classic hyperopic LASIK pattern on their topography with central steepening. And this was a patient that was, again, motivated for a refractive outcome. We did a light adjustable lens on this patient. And for this patient, again, what's nice, they dilated really well. They were interested in some additional range, and so we'd kind of talked with them about, we're gonna do your dominant eye for distance, we're gonna do that kind of blended offset with your non-dominant eye, knowing that, again, you have some higher order aberrations, but a monofocal light adjustable lens probably is gonna have the least impact for those higher order aberrations affecting your vision. And so as we went through the adjustment period, again, treating that right eye, and this is actually also a great example. You know, we shot for plano in the right eye, and it ended up +150 -1, which is not uncommon for a
It's perfect. That is where I
hyperopic
would
LASIK.
want them to land.
Yeah.
It's perfect.
And ended a little more hyperopic than we wanted, but again, is also a point, if we put a basic monofocal in this patient and they ended up +150 -1, they're not gonna be very happy with their distance eye. And if we put a basic monofocal in their near eye and they ended up effectively spherical equivalent, they're gonna be like, well, why'd you put the distance lens in my near eye? And again, that's the variability we see with post-refractive cases. So the nice part here, we adjust the distance eye back to not having hyperopia or astigmatism. We start to induce some of that nearsightedness. And again, as you get into the end of this patient, 20/15 distance, J4-ish out of that eye. But again, nice J2 vision with their left eye, and take them to -1. Don't have to induce that much myopia to still get really nice near vision effect, which is great.
And I think it's important for everyone out there to know when we do light adjustable lens, well, everyone can kind of do it differently. In Fargo, I'll say, you know, we just had this awesome conversation about how we're going to use this super cool technology and use this lens to give you good distance and give you good near, and we're going to trial it and we're going to adjust it. But for the first month, you're going to have no near. And you're going to say, you know, I spent more money on this and I can't read anything. With the light adjustable lens, it is so much easier to give more near than to take it away. And so for these patients that want both, best of both worlds, in the beginning, distance will be fine, their reading will be terrible until we make it better.
Yep. That's a great point. Last one, the case of the curvy cornea. So this is a 62-year-old male, history of with pterygiums on one side, Salzmann's nodules on the other side, 20/50, 20/60, 2+ nuclear sclerotic cataracts. Here's their clinical topography. So their right eye, which has the pterygium, you can see this classic flattening nasally where the pterygium's encroaching into their central axis. This demonstrates kind of circled as their higher order aberrations, so 1.16. We kind of like to see that be, less than 0.6 or 0.7. The eye with Salzmann's nodular degeneration, again, significant flattening in the area of Salzmann's nodules, a highly irregular higher order aberration profile, and a lot of astigmatic effect from that. So if we were to just jump right to cataract surgery, this is a patient who really, with that degree of irregularity of their cornea, their only option is a basic IOL. But a lot of these patients, even if they say, hey, I really just want to do a basic IOL, their image quality that they're going to get even with a pair of glasses afterwards is going to be best if we treat the cornea first. And it's also maybe going to open up some other opportunities for them. So this is a patient that we did pterygium surgery. We worked on the cornea first and had some patients. So we did pterygium surgery on the right eye. You can see their higher order aberration profile go from 1.1 down to 0.2. And again, still have some nice with the rule astigmatism, but no induced higher order aberrations at this point, and a lessening of the actual measured astigmatism that they have. The left eye, very dramatic, and we see this a lot with Salzmann's nodules. Again, previously, their wavefront was measuring 7 diopters of astigmatism, their corneal topography. Decreases that down to 1.5. You can see the axis, again, a very nice, non-skewed topographic change, and again, low corneal aberrations. So give this patient 3 months to heal. Now you have these clinical topographies with low corneal higher order aberrations. And this patient now has kind of all these options of lenses at their availability. And quite frankly, a pinhole optic is not going to be a great choice because their higher order aberration profile doesn't deem it necessary. This was a patient who was highly interested in freedom from vision, from glasses for as much range of vision as they could get. And so we did a diffractive implant for them. And again, got a really nice outcome. But that's with a lot of coaching, with a lot of understanding. They got to be very patient. They're going to have 2 procedures that are painful and uncomfortable. They're going to have a 3-month period of waiting for that to heal. Their existing glasses or contact lens prescription is going to be very different during that time period. This was actually a family member of an optometrist here in the state. And so they understood that, they were well coached on it, and really did fantastic with this lens choice and being patient throughout the process. So the last question I will put, I'm going to pull just up here. If you were having your 2 eyes done for cataract surgery, would you guys do them on the same day, a day apart, a week apart, 2 weeks apart, or a month apart? Rapid fire, Colonel Mustard, your own eyes.
Both eyes, same day. Why not?
It's here.
Are you doing it for free?
Insurance would let you do it however you wanted.
Same day.
Same. Yeah, I do same day.
Miss White,
1 day.
1 day apart?
1 day.
Oh, you're a contrarian. Why 1 day and not the same day?
Conservative.
Sounds good.
1 day.
So, traditionally, we used to do it a week, 2 weeks, a month apart. For 90+% of our patients, we now do it a day apart. And I think for patients, and particularly for family members of patients who are bringing their family member to have surgery, it's an amazing win. It also decreases the period of anisymmetropia. I firmly believe the standard of care for someone who's greater than -2 or +2 should be that they have their surgery a day apart in today's day.
They studied the fall risk when you wait a week, and patients fall more often when you do them a week apart.
Yep. So again, I think it's a huge win for patients to be able to do it a day apart. I would definitely do it the same day if I had. Again, the limiting factor to that right now is insurance. Someday, hopefully, I'll be able to say from stage we're doing it the same day. But for the time being, we do all of our surgeries a day apart, and patients really, really enjoy that. I do tell them, the day after the first surgery, when we're doing their second surgery, that's going to be a blurry day because the first eye is going to be 24 hours out from surgery. They're still going to have some dilation. They're still going to have some corneal swelling at their incision site. That's going to be a couch potato day because we're going to make their second eye a little blurry, and they have to be okay with kind of a day of blurriness to then be able to have one healing phase, which is really nice for them. The other thing that I just wanted to emphasize, particularly around just cataract surgery as a whole, whether someone's doing standard basic cataract surgery or refractive or advanced cataract surgery, we're always emphasizing to these patients, this is a multi-step process. So if somebody's choosing a basic monofocal IOL, they have to understand, yes, you're going to have cataract surgery, but then you're going to be finishing the journey from a cataract perspective with a pair of glasses, whether that's reading glasses, a progressive lens, or a line bifocal. They have to know it's a multi-step process, and they might have a third step of a YAG at some point. And similarly, on the refractive cataract surgery, yes, they're going to have the cataract surgery, but again, it's a journey, and they may need a YAG, particularly if we see early PCO and a diffractive trifocal. They may need a refractive fine tune or a laser fine tune at 3 months if they have any refractive error. And so understanding that that is a journey, and the length of the journey, the way that we describe it and the way that I think of it is sort of the first 3 to 6 months are really about optimizing their image quality by optimizing their eye. So, do they have a plano refraction? Is their tear film pristine? Do they have regular epithelium with a smooth anterior stroma, a well-centered IOL, a clear capsule or a capsule that's been yagged, and hopefully, a vitreous that's not obstructing their vision? If they have those things, then over the second 6-month period, once we've optimized those, then they're going to go through the period of neuroadaptation for whatever lens they have, a toric, if they're doing monovision, if they're doing extended depth of focus or a trifocal lens, where their image quality will continue to improve over that time period. And so, again, when we see a patient who's unhappy, whether it's a basic monofocal, a toric, extended depth of focus, or multifocal, these are kind of the things that we're classically thinking about. And I would say, for the majority of patients, refractive error, dryness, and PCO in Montana are kind of the 3 big things that we're hitting at first. And particularly for an advanced implant, we want to hit their refractive endpoint. And so making sure that that's crisp and clear. But in order for that to be crisp and clear, we need to make sure that we're treating any dryness that they have, any PCO, so that we can get the best refractive outcome for them. And then this is more just maybe FYI for your patients, as we see them and then as they're coming back to you. We have kind of engaged in what we call kind of a just-in-time information. So as was mentioned by Nick, patients get a lot of information, and that can be very overwhelming in the setting of their evaluation. And even though they go out with a lot of information, both written form and otherwise, they're still going to be like, what did they say about the day after? What did they say about the week after? What did they say about the month after? And so most of your patients, if we're seeing them, they're going to have videos that are kind of timed out to arrive, hopefully when those questions might arrive. So they get a video from me they get right after surgery, and a week after surgery, and a month after surgery, that just reminds them of, hey, here's the things that you might be expecting. And again, they're still going to be having conversations. Those are not meant to undercut the conversations that you might be having with the patients, but they're meant to really be supportive of those and to help meet patients in their kind of moment of need and question so that they can handle those the best they can. So with that, we'll see if there's any additional text questions. I'll put the codes up, and Susan will be walking up while we see if there's other questions.
Yeah, there was a question asking about anybody's experience up here in using one of the presbyopia drops, Viz or Vuity post-cataract surgery. Anybody have any experience with it?
So I'll throw, not Viz yet, although we were part of the FDA trial. We're going to talk a little bit about that. Certainly for the extended depth of focus lenses that are wavefront modulating, so Vivity, there's great clinical data to show that the extent of depth of focus they get is pupil dependent. So a smaller pupil, they will get a greater extended depth of focus. You're kind of getting 2 extended depth of focus, the pupil effect and the lens effect. So you can use that for patients. Again, most of those patients we've counseled that they're gonna need reading glasses for up close. So it's atypical that we've done it. We have had a few patients that we've trialed it in, and I would say with mixed success.
I can say I don't have any direct experience with it. I think for what we've seen in one of the studies that we did, I kind of would educate patients that it's very individual as far as the results you get. Some patients that were in the study did very well, improved near vision, didn't impact distance. Other patients said, yeah, it may improve a little bit, but it doesn't eliminate my need for reading glasses, or it doesn't last quite as long throughout the day as I'd like. I actually prescribed a patient Vuity yesterday. He was a monofocal IOL patient, 20/25 distance, doing well. Actually, one eye was a bit of a train wreck from somewhere else, and Russell had to put a secondary IOL in it, and he's doing great, but immediately he's like, you told me I wouldn't be able to see up close, and I can't see up close. What are your thoughts on these drops? And I said, let's give it a shot. It's not going to hurt anything, but more to come on that.
Yeah, and it's a great point, and we'll talk in the research part. When we did the study for Viz, that was done on presbyopic phakic patients, but they also enrolled an arm of that in pseudophakic monofocal IOL patients. So there is actually great data that there still can be some positive effect there.
Could you also quickly speak to a YAG capsulotomy on the pinhole IOL on the Apthera lens.
Yeah, so yagging an Apthera lens or a pinhole lens is not spectacularly fun. And the reason it's not spectacularly fun is you can't direct the YAG energy into the pinhole part. You will damage the lens and the patient will get some really unusual light phenomenon. So the rule of thumb, hopefully the patient dilates well enough that you can direct all of the laser energy outside of the optic. You can direct laser energy in the central part, but you ideally have a patient that dilates well enough that you're, instead of doing like a classic cruciate or kind of cross pattern, you're doing a circumferential YAG treatment all the way around and trying to stay, if possible, if they dilate well enough, trying to stay at least a half millimeter lateral to the edge of the pinhole. So, and those are actually patients, most 98% of YAGs that I do without a contact lens to help focus and stabilize the eye. Those are one patient population that I will put a lens on, just so you have a little extra control of the eye and so that they can't blink during the procedure or otherwise or shift their eye slightly.